Good afternoon, and thank you very much, Jack Krishnan, again for giving me this opportunity. And it's nice to be here, and thank you very much for our chairpersons for having me to give this lecture. My lecture is going to cover like a summary of all the morning lectures, so you have to bear with me, and in some way it's good because if you slept in the morning, you can wake up and listen to me, and if you are listened in the morning, you can go to sleep. So either way, it will fit what I'm going to say. So the litigation in obstetrics is covered in the United Kingdom by a special health authority called National Health Service Litigation Authority, and there's a scheme called the CNST, or Clinical Scheme for Trust. And depending on the total number of deliveries we do and total number of doctors and midwives we have to pay an insurance premium. So about 4 years ago, or 3 years ago, when I had a department, we deliver 5,400 babies, and for maternity there's a special insurance, and we were paying £8 million every year. So in other words, even before we deliver a baby, we had to put aside 600 to 800 pounds in case something goes wrong. We don't get the money back. And the reason is actually, as you could see here from the list here, the tallest is actually the obstetrics and gynecology. Next is surgery, less than 50% of what is in obstetrics and gynecology. This is not because we do far too many mistakes. This is mainly because for each litigation case, the quantum given is very high. It is given something like, for a brain damaged child at the moment, the going rate is 6 to 8 million pounds. So it's a lot of money. But for a small mistake like retained swab in the vagina, there is no contest at all. 15,000 pounds are written and given directly because that's the case. If it is a third or fourth degree tear, and if it is not repaired properly or not identified, then it is nearly 50 to 100,000 pounds. So it is quite a lot of money which goes per each, depending on the type of case. Sometimes we think if the baby is dead, then it is 100,000 pounds, but if the baby is alive and brain damage is 6 million. So we can't blame the parents because it is nothing to do with them, but it is because they need the money to look after them. Although the government looks after the children in a big way, they need additional money because they have to rush the child to the hospital, they need special facilities and so on. So the main issue here is how can we reduce medical litigation? What is the thing behind this big money? Now these are the main areas of contention. CTG is done, but in number of places it is poor recording. Sometimes the whole machine is running and people think it is CTG monitoring. It is not a monitor, it is really a recorder which is recording the heart rate. People think if you put the machine, everything will be okay. Secondly, misinterpretation. Thirdly, injudicious use of oxytocin. Sometimes they put the drip and forget about it, they don't record the contractions, and delay in taking action. Missed ultrasound diagnosis is again a major burden because because people are not very familiar with ultrasound. Thirdly, instrumental vaginal delivery and poor outcome, shoulder dystocia, and third and fourth degree tears. These are the top 5 or 6 causes for medical litigation in the United Kingdom. And this is just to give you one example. Usually, if there is only a simple mistake, is not a problem. But this mother says, 30 blunders by hospital killed my newborn baby. And they said the fact they continued to up the dosage of the drugs which was causing the damage and distress he meant that by the time he was born, he had no chance. So this baby was a full-term, nicely grown baby, clear amniotic fluid, and she was not progressing well in labor. They started oxytocin, the CTG was pathological, they kept on increasing, they stopped at 6 centimeter, but the uterus becomes more and more sensitive and hyperstimulation, and the baby died. So this is not an unfamiliar scene, and it comes in the newspapers every now and then. So I'm just going to take the themes which I discussed this morning and just put a little bit different picture. And shoulder dystocia was discussed this morning, turtleneck sign, which is actually the head comes out and doesn't retract or rotate, and that means spontaneous restitution does not take place. And even when she is pushing, the baby doesn't come even with gentle traction. So that's the diagnosis. And this is the management. You heard about the mnemonic called HELPER, and this is to help. McRoberts maneuver, which is flexing or hyperflexing the thigh and the knees and abducting, and then anterior dissection by rotating and adducting the shoulder to an oblique diameter by directed suprapubic pressure. So you must go in a direction from behind. Consider episiotomy, or if it is already there, it is extended, and then the rotation manual. I just want you to really pay emphasis only on two things with shoulder dystocia. Number one, and as discussed in the morning, nearly 60-70% of shoulder dystocia cases are of normal birth weight. So for them, actually, McRoberts maneuver and directed suprapubic pressure will work. You don't have to worry too much about that. The ones who get into greater difficulty are those big babies. They look like sumo wrestlers, big cheek, big shoulders, and they get stuck. And they are the ones which needs help. And they are the ones who run into difficulty. And in those cases, you can't rotate them very easily with two fingers. You have to put the whole hand inside and rotate with the whole hand. And unless you can put the hand, you won't be able to rotate them. So that's the first thing. The second thing is actually, as discussed in the morning, by removing the posterior arm or the anterior arm, usually the posterior arm where there's more space, you will reduce the diameter considerably, because McRoberts will give you about 0.8 to 0.9 centimeter leverage. But the Barnum's maneuver, where you deliver the posterior arm, will give you anything from 0.5 to 3 centimeter, and we will examine that very closely. So these are the two things, and putting the whole hand in is called the Pringle or the Bangle maneuver. You just put the finger there and squeeze your hand right inside the pelvis in order to achieve that. So this is McRoberts maneuver, as you can see, when she's lying down and when she's hyperflexing the thigh. You can see there is a 9 millimeter leverage. Not very much, but that's quite enough for many of the shoulders to come through. This is directed suprapubic pressure, so the person who is applying the pressure has to be behind. So this is anterior fontanelle, this is the baby's face. So when you rotate, not only the adduction of the shoulder, but it rotates and comes out, because this is a natural axis and you should be able to rotate to the right place. And otherwise, you have to put the hand. Now, people always worry whether to put the hand anteriorly, posteriorly, and so on. I think the important thing is actually, if you're going to rotate, put the hand wherever it goes easily. But it is usually posteriorly you will be able to, because anteriorly you might find it difficult, and you might be able to do it posteriorly and rotate. Otherwise, you have to stick to the Barnum's maneuver, where you put the hand, and today eloquently they discuss Justus Hofmeier using a nasogastric tube, try to deliver the baby. But it doesn't matter when you do this, because if the fracture of the humerus, it will heal well. Whereas if you cause brachial plexus palsy, then it's a major problem. So this is actually removing the posterior arm, and you can do that. And the major advantage here is when the baby is trying to come out, the biacromial diameter is much larger, and once you have removed the baby's hand out, the axilloacromial diameter reduces by 0.5 to 3 centimeters. So 3 centimeters is a big gap. And that we did some study. This is Jane Kung, one of my medical students with whom, and the house officer, we published that if you take 100 babies on an approximation, you can reduce the diameter from anything from 0.5 up to nearly close to 3 to 3.5 centimeters. And what we did was actually a very simple experiment, taking all the babies of different weights and lying them on a mattress, on a white mattress, and drawing a pencil line on both sides when the arms are like that, and when the arm is lifted, you write a line, then you measure the circumference and the diameter, and then show there is a major difference. And here this is the axilloacromial diameter, that is after the arm is extended. This is the biacromial diameter. So if the biacromial diameter is 16 centimeters, the axilloacromial diameter is less than 14 centimeters, 2.5 centimeters different. If the biacromial is 18 centimeter, the axilloacromial is about 14.5. So you can see a significant difference by reducing the arm, by just taking it out. Not only the diameter, but the circumference. So you go around, the circumference is also, so if it is a biacromial circumference, if it is nearly 45 centimeters, if you look at the axilloacromial, it's 35 centimeters. So it's, in terms of circumference also, you are reducing a huge amount. 10 centimeter difference is quite huge. And the biacromial, interestingly, has some relationship to abdominal circumference. So when you do an ultrasound, if you find the abdominal circumference huge compared to the head, that is an asymmetrical macrosomia, you're going to be in trouble, because that has some correlation to the diameter as well. So it is well known. So when you look after diabetic, post-term, obese mothers on ultrasound, if the abdominal circumference is large compared, say, if the AC is on the 90th centile and the HC is on the 50th centile, then you're asking for trouble, because those are the ones who run into difficulty. The difficulty is because with the normal traction, you apply 45 to 60 newtons, and if you have even slightest difficulty of biacromial dimensions, you will increase the force by 100 newtons. So about double the amount of pressure with which you have to, or force with which you have to pull. So MacRoberts maneuver is very good, because by increasing it even by 0.9 or 9 millimeters, you will be able to reduce this to 45 to 60 newtons. And if it doesn't, then you have to looking at the delivery of the posterior arm. This was mentioned earlier in the morning. There are 4 things starting in P. Don't panic. Don't pull on the head. Don't push on the fundus. Don't pivot, because it's a habit for people to depress the head. And when you pivot the head at the bottom, the brachus plexus palsy gets stretched, and that might cause problem. And it is shown that the nerve injury happens with the first forceful manipulation. So if there's a junior doctor who has struggled, and then call you, you might go and do the best Barnum's maneuver, but still the baby will be injured, because the first vida caused. Or if it is persistent manipulation, then it will give rise to injury. That's why shoulder dystocia drill and practicing is quite important. And again, to mention the Bangles maneuver, where you have to put the whole hand, and the Barnum's maneuver, where you deliver the posterior arm, are quite useful. Extended episiotomy is necessary if you want to put the whole hand in, and I mentioned about these particular maneuvers. Now there are other things you have to be worried about, because if it's a big baby, then there could be a possibility of PPH. Measure the pH, because the pH drops quite rapidly. The baby might be depressed. Examine the baby. Explain the delivery and maneuvers to the parents. It's quite important. And chart or record what was done. And it was mentioned this morning, I think news had mentioned that take the college guideline, in the appendix has that. You can reproduce that and fill it. So the medical legal issues are failure to anticipate based on antenatal interpartum risk factors, which was eloquently mentioned this morning. And if there's a suggestion of possibility, failure to discuss the rare events. Now when I go to the ward, labor ward, and do cases, if there is a big mother, diabetic, I'm anticipating there's going to be a problem because there was an abdominal circumference which is big, I normally speak to the couple there and then and write on the notes, beware of shoulder dystocia, and when she's about to push, the midwife has to call another doctor to stand by and the pediatrician to come around. If everything goes well, nothing to worry about. So anticipation is quite important, and getting ready. And the other reasons are failure to get adequate help, failure to do stepwise maneuvers and explain the outcome, failure to record events, failure to anticipate post-operative complications like PPH, third-degree tears, and so on. So to avoid litigation, you have to practice on mannequins. And there is something called negligence versus error of judgment versus no negligence. If you have prepared everything and you have done your best and something has gone wrong, then they will say you are not negligent. You have tried everything and this is what happened. On the other hand, the previous list I showed you, if you didn't anticipate, if you don't prepare, don't ask for help, and something goes wrong, then you'll be negligent. Now, always there is a saying that there are no experts in predicting, preventing, and managing shoulder dystocia, but there are many experts, medical witnesses, who are really armchair obstetricians, who don't practice any obstetrics, who suggest whether the process was acceptable or not. Because the people who I have seen some gynecologists and oncologists who give expert evidence about shoulder dystocia, because everybody is happy to comment, but nobody is prepared to do the delivery. So it's quite important that the judge and the lawyer will base their judgment on what you have written on the clinical notes. So this particular section on shoulder dystocia, we have to remember, is largely unpredictable, complication of pregnancy, beware of large babies, be prepared, carry out drills. And this is called like Girls' Guides and Boy Scouts and so on. You have to be prepared, carry out the drills, and safe delivery of a live, healthy baby. That's our way. Now, the second area is actually about intrapartum stillbirths and neurological injuries. Now, in 1997, there was a report saying in the UK they lost 1,300 term babies. And 2007, they said there were 500 missed opportunities, as you could see here from the date of birth and date of death. And the chief medical officer, Sir Liam Donaldson, said, we must do something. You can't get the mother having a healthy baby on admission to the labor ward and then going home without a baby. So this is terrible. And when we analyzed some of the cases, it was very clear. There was failure to interpret the trace properly, failure to incorporate the clinical picture, failure to act in time, failure to have good quality tracing, escalation of oxytocin in the presence of pathological CTG, and recording the maternal heart rate instead of the fetal heart rate. So the common mistakes which we discussed this morning. Now this is the recording in a case, and the midwife is looking after. What can you see from here? You can't see anything, except the baby's heart rate is terrible. You can see from whatever you can see is, and this is going on. And if you really look at it, this is starting at 19 hours or even before 19 hours. And this is going to 1940 and going to 2010 and so on. And the midwife is happy because she can see the head coming there, but she's not bothered about the heart rate tracing. And what happens at the end? The baby delivered normally. It was a direct OP, that's why it was taking such a long time. And baby was flat and floppy and transferred to an NU and very low Apgar scores, developed cerebral palsy. We can't defend that case, and that is because of poor recording. So that's one of the problems which happened. Secondly, failure to recognize hyperstimulation. They were thinking 1 in 2, it becomes almost 1 in 1 with this bradycardia. And they didn't recognize, even though you don't touch the syntocin on infusion, the uterus will start contracting more towards the late first stage and second stage, and they must stop the oxytocin. So this baby is again damaged. The third thing, they know that because of the spontaneous increase in uterine activity when somebody is on oxytocin, if there's a bradycardia, the machine has a tendency to double the heart rate, which is called the electronic window phenomenon. So here the heart rate is 75 and it doubled count to 150, and the obstetrician thought this is fetal and this is maternal. After 50 minutes they delivered, very bad pH, and obviously the causation is very clear and the liability is very clear. And this is about the maternal heart rate. I showed this morning, and here is a poor recording. They said vaginal examination fully dilated, heart rate is 150. 20 minutes later, it settles down to 120 baseline and what is called accelerations coinciding with the contraction. And physiologically, when the head is pushed through the uterus or the pelvis, it should be showing deceleration. And acceleration in the second stage like this is due to coinciding with the contraction. These are maternal heart rate. And the mother's heart rate goes up tremendously, like one of us going on a treadmill. And people don't realize. Sometimes I see the midwives are written pulse rate 80, 82, 88, 86 and so on. You go and count, it's 120. And it is not, and if you record it continuously, you will realize. And this is the same thing. This is going for 1 or 2 hours, nobody thinks, and then the baby is born. I've got 0 at birth, 0 at 1 minute, and they wonder why it has gone wrong, and they didn't realize they were recording the maternal heart rate. So you can see this is the problem. And the cord gas seems to be okay, although 1 hour later is low. This is because when the cord gets compressed and there's a bradycardia, you take the blood from the proximal segment of the cord, which will have a good pH. So if you take it from the distal segment, you won't have it. So they think everything is okay. And Dan Sherman put some electrodes on the maternal chest and showed that in the second stage, when the mother pushes, the heart rate goes up. So this is well-known phenomenon. And the next mistake is escalation of oxytocin in the presence of pathological CTG. And this is syntocinon, the heart rate is 150, the heart rate is becoming worse here. And at this point, they should have stopped the oxytocin, but they decided they will continue the oxytocin. The baby was born in a very bad condition, and obviously the contraction virtually every 1 to 1.5 minutes, we can't defend it because they should not have expressed it. Now, the next issue is actually sometimes the babies are already compromised and people don't recognize based on the CTG. She is saying fetal movements are less than before, and she comes in, membranes intact, and the CTG was like that. I mentioned this morning, if the baseline variability is markedly reduced, these shallow decelerations are blunted CNS response, and there are no acceleration. So what happens, as I showed you here, the cardiotocograph was seen by the midwife and the registrar. They were a little bit worried, so they decided to call the consultant. The consultant came and said, "Oh, well, I'm not very sure. Let us look at it 1 hour later." And the interesting thing is actually, this is very common in the UK, that when you look at the timings of these things, if they are going off duty in 1 hour, they will say review in 1 hour because they won't be there. So it's a very happy medium, and this goes on. I can see another hour has gone, and 5 o'clock. Then the woman complains of brownish greenish discharge on the pad. The midwife examined, and there is brownish green stain. There is no obvious liquor. And it should have rung the bell to the midwife, it is meconium. And it's a cephalic presentation. She said, "Well, I don't want to do a V." Now people are averse to do another vaginal examination. She said, "I will do a V next time. 4 hours I had to do. So I don't want to put a finger in and see what's happening." And it was thick meconium, and they missed the opportunity because with the CTG and the thick meconium, they would have done something. And this was going on. And they didn't tell that to the senior registrar who came on duty at 5 o'clock. He thinks the contractions are poor, so he puts the nail on the coffin. He puts the oxytocin on top, and then obviously the baby could not tolerate, comes down, they rush and deliver a baby, and the baby has HIE. So it's a poor understanding of the CTG. So overall, I've been generally promoting the use of a central monitoring system, because this central monitoring system will automatically archive the CTG. But more than that, I call it the neighborhood watch. That means somebody on the central station will recognize when CTG is going wrong somewhere. Even if the midwife or the doctor inside the room doesn't recognize it, somebody else will pick it up. So when I do the labor ward round, I just scan all the traces just to make sure it is fine. And you can have a monitor in the office as well, and that is a good way of trying to identify what is going on. So that is about the CTG. Number of mistakes continuously goes on. We keep on mentioning that, but there is very slight improvement. Sad, but very slight. Now we go to assisted vaginal delivery, and we know when things go wrong, they ignore the mechanical warning signs. So the size of the pelvis, the partogram, how it is progressing, and the basic rules are disregarded of assessing the head position, seat station, and the fetal ear, and also the CTG. That's part of the assessment, fetal compromise. And delivery is undertaken by 2 junior or inexperienced doctors, and repeated attempts at delivery, and delay in decision to delivery interval. So let us look at something. This is actually a baby born with the forceps. This is a baby born with the vacuum. Both should not have happened, because the forceps is supposed to go just behind the eye, across the ear, because it pulls on the zygomatic strut. So it's a bimalar bitemporal application. The distance between the blades are smaller compared to the biparietal application. So it is really here because when you apply here and pull, the flexion point is here, right there. So here, if you put the forceps and you can't lock the forceps, then there is some asynclitism or malposition. If you forcefully lock it, then that will come and there is a telltale evidence. And here it's a paramedian deflexing application. So both, nobody has to give any witnesses. It is very clear from the picture that's the case. So it is quite important from very early days in training that we have to keep a skull like that and ask the registrar, there's nothing else to do in life, go and palpate. And if it is worse, the molding remains for some time. And in the baby, I can show you, this is actually a stepwise molding. So ask them to wash the hands and go and palpate, because that will show the molding and the caput. And as you could see, this is the biparietal diameter. So when they do an examination, if they can feel the fetal ear quite comfortably and it is coming down, then the biparietal diameter has passed through. So it's quite important just to see and stretch and see whether they can. And you can see the baby's head is like an egg. So when you apply, as mentioned this morning, anywhere near the occiput here, you will be putting a cap here and pulling the baby. And if you put a bimalar bitemporal application of the forceps coming in front of the ear and around here and pull, then you will be pulling through the flexion point. So the same principle applies whether you're a vacuum or a forceps, you have to do that. And it's quite important to make sure the sagittal suture cuts the pelvis into half. If it is posterior asynclitism, like here where the parietal bone is felt posteriorly more, then there's a problem. And if you're going to apply, then you have to apply the vacuum in such a way, or the chelans in such a way, that you'll find the vacuum should go there, because when you pull, automatically it will correct itself, and as it traverses through the pelvic floor, it will rotate. And same with the chelans forceps once you apply and rotate. Now, this is actually a facial palsy, as you could see here on this side, the nerve is paralyzed. That is no problem in terms of the application. If the baby is sometimes big, sometimes it gets compressed, it gets cured. On the other hand, this is a problem because they couldn't lock the blade, so they pushed one blade a little bit more, it impinges on the brachial plexus and also on the phrenic nerve. So when they do a radiological screening, that part of the diaphragm is not moving and it doesn't recover sometimes. So it's quite important that not to be rough with the blades. Use as if you are using a pencil in terms of application. I showed you this very clearly. So the well-flexed head is suboccipito-brachmatic, 9.5, biparietal is 9.5, and this is the baby's head. So if you apply here on the occiput, this is 9.5, and you can easily take the baby out. And if it is deflex, it's 11.5. So that's a bigger diameter, and you will have more difficulty in coming. I mentioned about the OT and OP position, because if the OP, the vacuum cup has to go there. And if you use a cup with the stem coming to the dorsum of the cup, then you can't shift the cup to the occipital region. So a silk cup, you can't apply to OT or OP to get the best advantage. So if you have got two cups here, both look alike, but this is the cup you will use for OT or OP because you can slip it between the vagina and the head. So this is called the posterior cup. That is an anterior cup. You can have the string here, or you can have another thing to pull. And this is again the O'Neill cup. This is posterior and that's anterior cup. So it's quite important to use the appropriate cup for the delivery. And Kiwi, the Omni cup, can be used for both because you can apply there or apply by slipping it through. So the protocols and guidelines have to be there. Regular ward rounds with the senior obstetrician to really see an objective structured assessment of technical skills are quite important, because if somebody is unfamiliar with the task, there is 17 times making a mistake. And I think my esteemed next speaker will talk about avoiding errors, and this is actually error producing conditions. And if you're a good obstetrician, even if you have a disturbed sleeping pattern, you have only 1.5 times chance of making a mistake. But if you don't know, then it's 17 times. If you make a shortcut, it's 11 times. So it's quite important that the final one I want to touch is actually about the obstetric anal sphincter injuries, which are discussed about the anal canal. And it was eloquently put this morning. about the internal anal sphincter and the external anal sphincter, and this diagram was shown about the external sphincter and the internal sphincter, and how it is a thick condensation, and whereas the external sphincter is striated and is separated by the conjoined longitudinal muscle. And there are a number of risk factors which are discussed, so I'll skip some of those because these are the ones which are well known or associated with the obstetric anal sphincter injuries. And the perineal trauma, Abdul Sultan, who works in our hospital setup in Mayday Hospital, he made a lot of studies on this particular problem, and he made especially a distinction when it comes to anal sphincter involvement into third degree and anal epithelium as fourth degree. And if it is third degree, 3A, B, and C, A is less than 50%, B is more than 50%, and internal sphincter torn is then it'll also, beyond that, it'll go and breach the anal epithelium. So he and Juan Fernando, who worked with him, did his MD, and I examined his MD, and they recommended the overlap technique. Although there is it's one or two studies, so you can do an end-to-end or overlapping technique as shown this morning. And this all mentioned here about the Vicryl 3O, and it should be in the lumen. Again, there is some controversy, but this seems to be accepted. And internal anal sphincter 3O PDS, and external double-breasted with PDS suture. And intraoperatively, these are the things, the antibiotics, and then postoperatively to soften the stool so that they don't strain and break the repair. And follow-up is quite important, and if you have facilities, you can do an anal manometry, but even otherwise, just to see what happens. Now, third and fourth degree perineal tears are not uncommon. In our hospital, Abdul Sultan came and spoke to me, and we put in our maternity dashboard, our incidence is 1.5 to 2%. He said, no, it can't be 1.5 to 2%, it must be 3 to 4%. I said, no, we are better obstetricians, so, and I was trying to tease him. He said, no. He got a chap called Andrew Vassant, one of the registrars, he got the money for a research, and he said, every case, if it is more than second degree, there's some doubt. This chap has to go and put a finger, because once you put the finger in the anal canal and just push it up, then you can see whether the anal sphincter is torn or not. If you superficially look at it, sometimes you miss it. So our incident suddenly went up to 3 to 4% from 1.5%. So it's actually failure to identify sometimes is a problem. And the woman might come, as mentioned by the eloquent lecturer this morning, they might have this as a silent agony. They don't come and tell they are passing flatus and they are incontinent for flatus, although they might be continent for the feces, and usually the liquid feces and the flatus, which is a major problem. So the failure to identify is one of the problem. Didn't apply the right technique. Overlap technique is preferable, not that end-to-end is fine. Poor intraoperative and postoperative care, poor counseling and follow-up with a specialized doctor. Now in our labor ward, it is very strict protocol that it cannot be repaired by a very junior doctor. It should be repaired by the year 6 or 7 registrar or the consultant. It should be done in the operating theater under regional anesthesia, as mentioned by the speaker this morning, because the striated muscle of the external anal sphincter, it is difficult to approximate and cuts through if there is no relaxation. So it's quite important, and that is meant by poor intraoperative or postoperative care, poor counseling and follow-up. Now how do we follow these cases up? We have the maternity dashboard. I'm sorry of the small figures. If you go into the Royal College website and for good practice guidelines, we put 4 things together, and one is actually the clinical activity. The second is about staffing in terms of ratio and whether they are going for CME activities. The third is clinical outcome in terms of operative, cesarean section, urgent, elective, instrumental delivery. And the fourth is actually about complications, postpartum hemorrhage, anal sphincter damage, shoulder dystocia, and the final part is about complaints. And we mark the complaints, whether it is due to medical mistake, whether it's due to communication and behavior or attitude, which we say we should have 0 tolerance, and whether it's a system error. So we have 3 types of complaints we divide. Now we maintain this because, and also we give what is green and what is red. So for anal sphincter damage, if it goes more than 3%, then we are very worried. So that means that will go on red. So what do we do when this happens? We call all of them. We have a Saturday class for all the registrars and consultants. We get some pig anal sphincters and ask them to repair. We get Abdul or Rani Thacker and we ask them, and our own urogynecologists, we ask them to repair all the time, because I think it's important. They must know that they have to avoid by giving a good mediolateral episiotomy. We send a note immediately after the month statistics is published. We ask them to say, okay, please make this mediolateral episiotomy. And there's one trick I just want to tell you. When you make an episiotomy, and if you know the vaginal introitus is there and the anal canal is there, you might cut. And if you cut very close to the anal sphincter, it just curves around and goes towards the anal sphincter. The only thing you have to do is you don't have to cut deep, but if you cut only the skin, a little bit superficially, beyond the point of the anal sphincter there, or the anal canal, then it tends to tear and separate the muscle and the tissues in between. Same will apply internally on the vagina. If you want a little bit more, if you can't see the shank of the blades, then you cut a little bit above. And I forgot to mention a little bit about application of the vacuum and the forceps, which has been discussed very eloquently this morning. Before we pull, we say the sagittal suture should cut perpendicular to the shank. When you put a finger, it should be 1 finger breadth between the heel of the blade and the head on both sides. If it is 1 finger and the other side is 2, that means there is asynclitism. And the occiput should be 3 centimeters above the shank. Otherwise, you have to unlock the blade, take it up and lock it again, and then bring it down. So the 3 points have to be satisfied. Same with the flexing median application. The first pull comes down, the head comes down dramatically, and there are some marks on the kiwi cup, you will know. So whenever we find some difficulty on the dashboard, there is a problem with third-degree tear, there's a problem with instrumental delivery, like failed instrumental delivery, for example, or trauma with instrumental delivery, or shoulder dystocia, we try to really sensitize the staff and also put in some practice classes. So if there's a CTG mistake, Saturday we organize a CTG lesson. Call all the midwives, doctors, give them a cup of tea and some sandwich, and ask them to carry on doing it. That's the only way you can improve. And the only way to improve is to know that we are making a mistake. Otherwise, I might think I had a third-degree tear. Others, the next consultant might have another one, but he'll think, well, it must be me only. But when you put it together, we know this is a big magnitude. So it's quite important that you have some statistics. And I was happy Nuzhat is maintaining one in Hyderabad. I don't know, I'll have to come and check on that. But she was saying we had changed the parameters at St. Joseph when she came the second time. The beauty of this dashboard is actually depending on what you think is a problem. Say if your problem is cesarean section rate, then you can expand on that scale. You don't have to really all the time, monitor the same parameters. So this year you can say, I want to check on how many babies are born with RDS. And then if the babies are born with RDS goes beyond a percentage, that is unacceptable. So then you do an internal audit to see how we can improve on that. So whenever you find a red label, there's a range which we put based on the college guidelines. What's the normal incidence? If it goes beyond that, we do that. It doesn't mean that you have to stick to that. Say, for example, cesarean section rate. Your cesarean section is 30%. You want to bring it down, then you put 24 to 28% as amber, over 28% as red. So every time you see it as red, so you want to bring it down. Once you commit to bring it down, the next 6 months you say, I want to bring it to 26 as the upper border to make it red. So our section rate is about 20 to 22% in a busy teaching hospital with a busy fetal medicine unit, and that's the only way we can. Now there are 3 good booklets you can download from the RCOG website. One is called Safer Childbirth. That is to do with the labor ward practices, which gives about the staffing standards you should have in terms of anesthesiologist, midwives and obstetrician. Then there are 30 standards in maternity care and 20 standards in gynecology. I would urge you to have a look at these because It is slightly different from guidelines. Guidelines tells us there is a condition, how do you manage, like chicken pox. How do you manage chicken pox? How do you manage shoulder dystocia, postpartum hemorrhage? How to manage a condition. Standard is actually the standard of delivery of care. If you go to a restaurant, this is the standard. It is clean, it's air conditioned, this is how the tables are set, people are smiling, etc. In addition to the food as well. So you don't ignore the food, but everything is there. So this one says, say the 20 gynae standards, has one on hysteroscopy, one on colposcopy, one on something. It'll say this is how the bed has to be placed. This is how you have to greet the patient. This is how you have to do that. Sometime when you read that, you think, should we be teaching all this to big obstetricians? The answer is yes, because most of the time you find it is terrible because they are not received properly and they are not. And also with the standards, there are some 3 or 4 bullet points, say auditable standards. In other words, what and what you should audit to make sure the practices are good. So that's the Royal College from in winter. Professor Piley is having a nostalgic look here, and that is actually the famous hall here, and this is a dome because up to that point underground there are lecture theatres. So when you go in there, you park your car, you have no idea there are 2 floors down because the government doesn't allow us to build upwards, so we had to build downwards in order to reach that. And that used to be my office for 3 years. And although the Regent's Park is just opposite, and when I took office, I thought I'm going to enjoy the scenery. And I can tell you, perhaps of the 3 years, I must have looked outside 10 times. The rest of the time, I was looking at the computer. So, and that resulted in these documents, working with them. And I'm happy that that was quite fruitful. So I'm happy to finish there, and thank you very much for listening, and I'm happy to take any questions. Thank you.